Good evening. I'm Dr. Michael Smith, a member of Suburban Hospital's Community Health Improvement Advisory Council, and also a member of the Board of Trustees of Suburban Hospital. I'm also representing the Montgomery County chapter of Alpha Phi Alpha Fraternity Incorporated, a health partner with Suburban Hospital. Thank you for joining us this evening for African Americans and colorectal cancer, a roundtable discussion. As part of the hospital's commitment to care for the health and well-being of its community members, we hope that this evening will be educational, informative, and also inspirational. Recently, we learned of the passing of Chadwick Boseman, a highly regarded young actor who had been battling colorectal cancer. His death serves as a reminder how colorectal cancer affects the African American community at a much higher rate, and younger adults are increasingly diagnosed with colorectal cancer. According to the American Cancer Society in 2020, about 12% of colorectal cancers, or about 18,000 cases, will be diagnosed in people under the age of 50 in the United States. In addition, African Americans are about 20% more likely to get colorectal cancer and about 40% more likely to die from it than most other groups. Tonight, we will hear from experts from the Johns Hopkins Kimmel Cancer Center, the Johns Hopkins University School of Medicine, Suburban Hospital, and also the president of the Montgomery County chapter of the National Panhellenic Council. But before we begin, I wanted to review a few housekeeping items. Tonight's program will be recorded on Zoom and will be simultaneously broadcast over Facebook Live. We have an open discussion tonight, and if you had a question, please use the question and answer feature on Zoom, or if you are tuning in on Facebook Live, please submit your question through the comment feature. In preparation for tonight's program, I'll start our discussion with a few questions to our distinguished panel. But we welcome questions from the audience. This format and program is for you. It is my honor to introduce tonight's panelists in alphabetical order. Dr. Neela Azad, Associate Professor of Oncology at Johns Hopkins University School of Medicine. Ms. Bertha Baloo, President of the Montgomery County chapter of the National Panhellenic Council, and also a member of Alpha Kappa Alpha Sorority Incorporated, Xi Sigma Omega chapter. She is also a 5-year cancer survivor. Dr. Ashwani Rajput, Director of the Johns Hopkins Kimmel Cancer Center for the National Capital Region. And last but certainly not least, Chaplain Phil Ridley, Director of Spiritual Care at Suburban Hospital. Dr. Azad is a member of the Gastrointestinal Oncology Program within the Sidney Kimmel Comprehensive Cancer Center, or SKCCC. She completed her fellowship in medical oncology at the National Cancer Institute and became a member of our faculty in July 2008. Since joining the faculty of the SKCCC at Johns Hopkins, Dr. Azad is the primary investigator of numerous early phase clinical trials in solid tumors and gastrointestinal cancers. Dr. Azad is a clinically active medical oncologist and is the co-leader of the NCI-funded UMI Developmental Therapeutics Clinical Research Program at the SKCCC. She is a member of both the Epigenetics and Colon Cancer Stand Up to Cancer Dream Teams, serving as a principal on the latter. She has been a member of the NCI Colon Cancer Task Force, the advisory board of the Biden Cancer Initiative, and executive director of the Cholangiocarcinoma Foundation, among others. Next, we have our distinguished panelist, Ms. Bertha Baloo, President of the Montgomery County, Maryland chapter of the National Panhellenic Council. Ms. Baloo is a 5-year colon cancer survivor. Ms. Baloo completed her undergraduate studies at the University of Kentucky, where she earned her BA in architecture and completed her MS in real estate development and construction at Georgetown University. She is a member of the National Architects Registration Board, Women in Construction, and the Georgetown Alumni Association. Bertha enjoys serving the community in various capacities through these organizations as they promote education, social change, economic and political empowerment. As president of the National Panhellenic Council of Montgomery County, Bertha has taken a special interest in health disparities, minority health, issues related to cancer, COVID-19, and all of us research. Helping the community is something her grandfather and parents instilled in her at a very early age, and she still continues this family legacy to serve. Next, we have Dr. Ashwani Rajput, Director of the Johns Hopkins Kimmel Cancer Center for the National Capital Region. Dr. Rajput specializes in the surgical treatment of colorectal, pancreas, and liver cancers. Dr. Rajput's research is focused on key signal transduction regulators of cancer metastasis. He is the author of numerous scientific journals. In addition to his clinical practice, Dr. Rajput oversees cancer services at Johns Hopkins Medicine's Sibley Memorial Hospital and Suburban Hospital, as well as Johns Hopkins collaborative programs with Howard University and Unity Health that are designed to improve access for patients living in Wards 7 and 8 in Washington. He is also responsible for the expansion of cancer clinical trials offered in the greater Washington area and the development of laboratory research enterprise in connection with the National Cancer Institute, focusing on bringing new treatments to patients. A graduate of Case Western Reserve University School of Medicine in Cleveland, Dr. Rajput also completed general surgery training at Case Western Reserve University and a fellowship in surgical oncology at Roswell Park Cancer Institute in Buffalo, New York. Chaplain Philip Ridley is Director of Spiritual Care at Suburban Hospital. He is a native of Asheville, North Carolina, and served in the Navy for 29 years, 17 of which were spent as a Navy chaplain. He has a Doctor of Ministry degree from Bethel University with an emphasis on congregational and pastoral care and a Master's of Christian Education degree from Mid-America Baptist Theological Seminary. He completed a clinical pastoral education residency at the original Walter Reed Army Medical Center in Washington, D.C. During Chaplain Ridley's military career, he spent 3 years at the National Naval Medical Center providing spiritual support and counsel to critically wounded and ill warriors and veterans, their families and staff. He supported care in trauma, med-surg, pediatric ICU, and oncology units. I'd like to give a welcome to all of our distinguished panelists. Well, let's start the evening off with a question for Dr. Rajput and Dr. Azad. According to the American Cancer Institute, colorectal cancer disproportionately affects the African American community. What exactly is colorectal cancer, and why do you think African Americans suffer more with this disease than other ethnic groups? Dr. Rajput.
Well, first of all, thank you, Dr. Smith, for your kind introduction and welcome, and it's a real honor to serve with this panel. So to answer your question, what exactly is colon or rectal cancer? Our bodies have a unique way of repairing themselves, right? So if we get a cut on our hand, our body knows to replicate cells to heal that wound. Cancer is such a thing where cells in the body start to replicate without any kind of control. And so there may be some kind of mutation that happens along with some kind of an environmental effect that results in this uncontrolled growth. And that uncontrolled growth can start in the colon or rectum as a polyp. And as that polyp grows and changes, it turns into a cancer. So that in its simplest form would be the definition of what a colon and rectal cancer is. And I think the second part of your question was, why are African Americans more affected by colon or rectal cancer? And like many things in medicine, there's no simple answers, but there might be some environmental factors that have a play. For example, we know that obesity can lead to certain types of cancers. We know that sugar metabolism not properly in the body, for example, with diabetes, may also result in cancer. A diet can play a significant role, one that's decreased in fiber and has more processed foods. And then the other thing becomes, how do we diagnose cancer? It has to be access for screening. And if we can screen patients earlier, we find the cancers earlier, and then we can treat them more successfully. And I'll turn it over to Dr. Azad to add anything else.
So I'm going to to echo that appreciation for being invited to this wonderful panel on a really important series of topics, and really timely right now as well, I think, in terms of getting out education about how we can really make a difference, because this cancer is actually one of the most preventable cancers out there, and yet it's still the second leading cancer killer. So I think we have a lot of opportunities here. You know, I'm really interested in particular in that second part of your question about why this hits our minority and Black communities harder. And there's been a lot of work that has been done to look at, are there actually biological differences in people who are Black versus people who are not, that might lead to this being a more aggressive cancer? And so far, that isn't what we're seeing. So in other cancers, like in breast cancer, there is actually a difference in the biology, what the cancer is actually like, and it can be more aggressive. But in colon cancer, it's actually one of the nice things is that we don't have a more aggressive situation when it comes to the cancer. But what we do have is built-in disparities in access to healthcare. And I believe that that is the biggest driving factor. You know, Dr. Rajput talked about a lot of important risk factors for cancer, and I think those are things that are also modifiable. But the big elephant in the room is the fact that our Black community is really significantly disadvantaged in terms of access to healthcare and access to screening. And because of that, this very preventable cancer that can be found as a polyp on a screen before it's even cancer is instead found at a more advanced stage when it's actually a cancer or a more advanced cancer. And that has been shown that stage for stage, people do the same. So if you have a stage 3 cancer in people who are Black versus people who are not, they do the same in terms of how they will respond to treatment. But we have many more patients that are diagnosed at a more advanced stage. And I think that speaks to some of the underlying serious issues in our country.
Thank you, Dr. Zad. That's so true. And thank you so much, Dr. Rajput. So true. So it's interesting, though, that COVID-19 has been upon us, and it has really exposed a lot of the disparities and inequities in healthcare, not causing them, but exposing them, making them come to the forefront. So a lot of what we have to do now is have real life conversations around these issues that face African Americans. So I was wondering, and this question is for all of the panelists, in your personal lives, how do you have conversations around cancer, particularly colon cancer, with yourselves and your family members? And if you do, how do these conversations come up? There are different realms, obviously, the professional realm with the doctors, but Ms. Baloo, and how do you have these kind of conversations since you've dealt with this yourself?
Well, the way I have the conversation, and first I want to say thank you, Dr. Smith, for inviting me to this panel, and I appreciate this opportunity and sharing with these fine doctors. But the way that I dialogue with my family is that my diagnosis, I come from a family of 5, and no one in my family ever had colon cancer. So once I was diagnosed, I thought it was important to share that information so that they could all be screened and see if there was any correlation with my diagnosis. So that was my approach to it, and just being flat out honest about, the condition, and if it's hereditary, I should know, or maybe someone didn't know. It's come to find out no one in my immediate family had colon cancer, so I was the first to get it after they were screened or to be diagnosed with it.
Could you share a little bit about what events led up to your diagnosis originally?
Yeah, sure. Well, it all started, I actually went away on a trip, and I got sick. And once I came back, I went to the doctor immediately. I was feeling uncomfortable. I went to 3 doctors. At the time, my primary care physician had moved away. And so I was already in search for a primary care physician. So at the time, I went to like 3 different doctors on this journey, and each time I was told nothing was wrong. It was water, or I've got seafood sickness, and I kept feeling this uneasiness within my stool, and so later, probably within a 3-month span, my primary care doctor that I was accustomed to going to came back to the area. I went to her immediately, and she did a certain number of tests, one being a stool test. I had blood in my stool, and she ordered a colonoscopy immediately. And from there, I had a colonoscopy within a week, and they detected that I had colon cancer at that time. And so from there, I had 15 inches of my colon removed a week later, as there was a pocket in my colon. And from there, I had 6 months of chemotherapy, as it was diagnosed as stage 3 colon cancer. And it had spread, it had broken the wall and had spread to my lymph nodes. So during that whole surgery of removing my 15 inches of my colon, they removed the associated lymph nodes. And that was, the basis of my colon cancer journey in 2015. So once I went through the chemo, I had, some extensive visits and scans and blood work. And October 26th with 2015 was my last chemo treatment. And today I'm cancer-free. My last visit was in August with my oncologist at Johns Hopkins, Dr. Cressel. And Dr. Bishop, a wonderful team of doctors on staff there. And it was a really intense journey, but through it all, I managed to stay positive. I think that's one of the keys, and not look at it as a death sentence, being that it was, stage 3 colon cancer, and also the spiritual aspect of it, as I come from a family of, my dad was a minister, and my brother's a minister, and so my prayer life was critical, surrounding myself with positive people, of course my wonderful sisters of Psi Sigma Omega chapter of Alpha Kappa Alpha, always keeping me upbeat, and others praying for me and adding some spiritual motivation for me when I couldn't for myself. So, because there were some times that there were some low times, but through majority of it, I just tried to stay upbeat, tried to stay positive, tried to, walk and exercise as I could, and of course during treatment, you're limited to what you can eat, staying away from things that are cold. You start to lose your senses and things of that nature. But, for the most part, just making sure that you don't be afraid to question doctors and question treatment. Like I said before, I was on a journey of finding a primary care physician. In that journey, I didn't feel like certain doctors had my best interest. And for me to push the envelope and say something is wrong, even though, it was, I felt irritated. My stomach didn't hurt to know that it was colon cancer, but I felt irritated enough that, these doctors are not, doing enough testing or recommending certain testing for me to find out what's wrong with me. So I think, you know, you really have to push and find that doctor that you're comfortable with, that's, you know, a doctor that is best for you and that you feel that, you know, is going to look out for your best interest.
Well, thank you. That was very powerful. That was very powerful. I'm glad that you're here with us. Chaplain, really, you tend to have to understand and hear about people's innermost secrets on a different level than family members. How would you address these conversations around cancer and colon cancer with the people that come to you for spiritual guidance?
After listening to Ms. Baloo's story, you have to realize that it's needed. It's not comfortable to talk about these sensitive issues, but it's so needed so that people know if it's hereditary or if other people in the family would have it. Many times in the diagnosis process, they ask about family history. And when you share a thorough family history, it helps the doctors to be able to diagnose you. So it's very necessary. How to remove the anxiety from having these tough conversations. That's just a step of faith and courage to be able to say, I have to do this. It's beneficial for me and my family to have this tough conversation. So we have to do it. My mother actually was diagnosed with breast cancer. Her sister had breast cancer and she didn't tell anyone. And we have 2 daughters. So my wife, when we found out, my wife actually told our daughters that their grandmother, their aunt, and a first cousin has had breast cancer in our family. So they'll be aware and know. So you have to break the cycle by doing it. And then maybe next generation and others will see we can do it and have this tough conversation.
Wow, thank you. Thank you, Chaplain. Getting back to our medical professionals, Dr. Rajput and Dr. Azad, Ms. Baloo mentioned that her initial symptoms was she noticed some blood in her stool. What are some of the other symptoms of colon cancer, and what are some of the treatments available for colon cancer? Dr. Azad.
So colon cancer can present in a lot of different ways. A very common presentation is to have blood in your stool that you can see. Sometimes you can have blood in your stool that you can't see, but that's microscopic blood and that's found on screening. But if you have blood in your stools, a change in your stool caliber, if it looks different, it's thinner, those are easier to diagnose in terms of at least saying that someone needs to have their bowel evaluated. I think some of the challenges are depending, especially on what side your colon, the cancer is. So if you have a right-sided colon cancer, some of the symptoms can be very vague: bloating, a little bit of abdominal pain, a feeling of indigestion, weight changes. And a lot of times that will get, I think very much to what you were saying, Ms. Baloo, that these things can get kind of folded into an assumption that someone doesn't have cancer. Because most times they don't have cancer. Most times you don't, it ends up being something that is benign, but it's always worth evaluating. And the younger you are, the more likely that you are to be, for it to be assumed to not be cancer. And we've also seen that that people of color are also, an assumption is made that it's not cancer. So speaking about what you were saying about how we need people to advocate for themselves, a lot of times it's not even that the primary care physician or the first doctor that sees you is not trying to do their best. It's just that their suspicion is low. And one of the big things we're trying to do in the oncology community is to educate the rest of the medical community about how high and how vigilant they need to be to keep this high on their list of things to rule out, because so much can happen by ruling it out early.
Thank you, Dr. Zad. Dr. Rajput, do you have anything to add?
Yeah, absolutely. Just echo what Dr. Azad was saying. You know, just recently, the United States Preventative Services Task Force also has recommended that the screening age be lowered from 50 to 45 for the general population. But, you know, it's that change in bowel habits, or what Ms. Baloo was talking about, knowing something didn't feel right. And so it's really important to be in communication not only with your body, but for your doctor to have that relationship that Ms. Baloo alluded to, that when fortunately her primary care physician came back. I think, Dr. Smith, you were asking about treatment as well, right? Correct? How do you treat?
That is correct. Yes.
Colon cancer? So we use a variety of tools in our armamentarium. First and foremost, like Ms. Baloo said, we use surgery. And the colon is a little different from the rectum being the most distal part of the bowel before the stool comes out. And so usually surgical treatment is first and foremost for most colon cancers. And then the staging that Dr. Azad and Ms. Baloo had alluded to impacts what we do after that. So if the tumor has broken through the wall, like Ms. Baloo said, and got to the lymph nodes, that's stage 3. And we recommend chemotherapy for that to help improve survival. Now, for the rectum, it's a little different. For some stage 2 and for stage 3 rectal cancers, we use a combination of radiation and chemotherapy, oftentimes before surgery, and then do an operation to remove that part that's affected by the tumor. And so it's a multidisciplinary approach with our colleagues in surgery, medical oncology, and radiation therapy.
Thank you very much. We have our first question from the audience. And audience members that are listening, please send your questions to the Q&A function on Zoom, and we will try to get them all answered tonight as best we can. The question is, what if people are afraid to get tested or don't know if they should because they don't have health insurance? What options are open to them? That's open to anybody.
Well, I'll jump in by first trying to reassure everyone not to be scared, right? So the first thing that can be done is just testing your stool for blood, right? Just like Ms. Baloo had. That can be a simple test either in the office or a test that you take home and then you mail that back to get those results. The colonoscopy, the worst thing is the prep, right? Everybody always complains about the prep. And that truly is the worst thing. Having had one, I can tell you. But when you go in for your colonoscopy, you get sedation and you really don't remember that it's happened. And so it is a very painless procedure. The second part of your question regarding the insurance is a little bit more complicated, but really speaks to the fact of what we need to do in regards to healthcare in our communities, right? But we do have options with certain clinics that take anybody who's having an issue or a problem. I think if you're having a concern, you can call into one of the clinics around in your community or to get help with a social worker at one of the facilities that might be able to guide you and navigate you to a facility that can help you. But you're right, it is a challenge in this day and age and worry about the insurance. But most organizations, if you come in and you have a problem, I know our organization will work with you to try and get you some kind of coverage and some kind of help. Maybe Chaplain Ridley could speak to that a little bit.
Yes, many times the social workers and the care coordinators, they can hook you up with Medicaid, Medicare, and other sources of funding for the various tests and medical procedures. And as you said, our hospital is very good about trying to figure a way to provide quality health care and not just say, oops, you don't have insurance, you can't stay.
I've been doing colorectal cancer care at Johns Hopkins for 12 years now, and I have never had a patient that we have not been able to treat because of insurance. So we have always worked it out.
Very good. Well, that's good to know because as you mentioned at the very start of our program, this is a preventable cancer if caught early and you do your screening. We have another question from Maria in our audience. Her question is, since blood is not always a strong indicator, sometimes bowel movements change based on diet. My concern is that it would go undetected for a long time until it's too late. Someone mentioned thinner bowels. Would this be frequent thinner bowels?
Generally, yes. So generally what you're looking for is something that is relatively consistent. If somebody has a one time where they go to the restroom and their bowel movement just looks different than usual, that probably isn't going to be something that needs further evaluation. That said, if you go to the bathroom one time and you have a lot of blood that one time, that needs evaluation. So bleeding the stool always needs evaluation. But if you just have a change in the caliber of your stools and it's not consistent, then that isn't usually something that requires added evaluation. But remember that things can be off and on over time. So when I'm saying this, I'm saying if you have a couple of bowel movements that are off and then you go back to your normal pattern, okay. But if you notice over 3 months that it happens regularly and then goes back and forth, I would still think that that really does need evaluation. So, trust your gut, not just your gut about going to the bathroom, but just trust your gut that if something is awry and it just doesn't feel the way that it has felt before, you should be evaluated for that. You should talk to a doctor you trust about that.
Very good. For the Zoom, people that are on Zoom, there's been a posting of a website. And if you live in Montgomery County, there's a free colorectal cancer screening program. And the website is posted on the Zoom chat. We have another question from the audience. It's from Mr. Ernest Franklin Jr. He states, my father died of colon cancer. Based on that, in my 40s, I began colonoscopies as advised by my doctor. My son will soon be 43. Should he also start colonoscopies? Dr. Rajput.
So, it also depends on how old your father was when he was diagnosed. But if you do have a strong family history, again, it's something to discuss with your physician primarily and what his risk factors are. But, he's close enough to that 45 age now. And if there is a significant family history, then it's probably wise to get started on the screening. And especially if he's having any kind of symptoms, it would be wise to get it done.
Great. So that leads us to another general question, particularly for the African American community. How can we get young adults to take preventive action against colorectal cancer? And exactly what steps should they take as far as preventive measures for colorectal cancer? Dr. Azad.
So young has a different connotation, especially now that I'm 44. And so, but as Dr. Rajput mentioned, 45 is now going to be the screening guideline. The American Cancer Society did that 2 years ago, and now the U.S. Preventative Service Task Force is going to make that 45 as well. If you're younger than 45 and you don't have a family history, because that puts you in a different category, then I think what we really need to do is be educating people. So education campaigns, when we lost Chadwick Boseman last month, there were a lot of articles that came out around that time that I think tried to highlight this. And I think that it shouldn't be when someone dies that ends up being the time that we take a couple of articles over a few days and educate people. And so I think, for those of you that are involved still with your sorority, Ms. Baloo, like this is something we could start doing with people in college so that they start knowing that this is something that they need to be thinking about as they go forward, and maybe talking to their parents about and pushing their parents to do things. So building them into communities, building them into, church events, building them into normal education. And we have educational programming around a lot of things. I mean, we can learn a lot from the breast cancer community. The breast cancer folks have been 20 years ahead of us in making sure that they're getting out there and making sure that they're educating people about what to be worried about. And so I think we can follow that paradigm and really make a difference.
Very good, thank you. Chaplain Ridley, you worked with military families providing spiritual care for veterans. But what role does spirituality play as far as in prevention of colorectal cancer? Dr. Azad mentioned some of the more scientific manners. Mm-hmm. Spiritually, what can we do to foster prevention of colorectal cancers?
Thank you for that question. Spirituality, from a clinical point of view, having worked at Walter Reed hospital with the military, there is like a technical definition for spirituality, where it's that inner connection of what helps a person know who they are or their purpose or their sense of being and safety. And I like to add to that clinical definition and say it's an external. Who are you? Who are you? And what gives you that sense of purpose and belonging? Because we have a creator, we have someone who has given us life. So when you include the creator in that equation and not just about yourself, then your behavior kind of changes because you're following your sacred documents, you're following your belief system. And with that said, your behavior changing towards your belief system, the Bible does discuss things about diets, maintaining diets. It talks about alcohol is good, but it also says that alcohol done in moderation is what is encouraged. It talks about fitness and how the lifestyles of those who are in the Bible was very fit and active. So those three things right there, if we watch our diet, if we watch our fitness and our health and activity level, if we do things in moderation like alcohol consumption, smoking, as well as participating with recreational drugs that are not prescribed. So drug usage as well is discussed in the Bible, to where we shouldn't be doing those things to our body. Our bodies are a temporal vessel that holds the true essence of us, which is our soul. So when we look at the bodies as a temporal essence, stewardship, and I know a lot of us hear stewardship, we think money, but stewardship of taking care of what's given to us, our bodies, is very precious. And it's also a sign of worship by being disciplined to apply what God has already taught us in order to live a better and healthier life. So a lot of people like to stay clinical about self-awareness, but for me, spirituality does include a deity, God, a creator who has given us life that we can respect and incorporate into our lifestyle.
Thank you, Chaplain, really. Yes, spirituality is very important. I want to circle back to Ms. Baloo really quickly. After your diagnosis and treatment, Ms. Baloo, what preventative measures did you change in your life to try to make sure that you wouldn't have some type of recurrence for the cancer coming back, or did you?
Well, in the career path that I've chosen and being a construction manager, traveling east to west coast, I ate out a lot. So, and that entailed, of course, probably a lot of processed foods. So I did cut that out of my diet. Wasn't much of a soda drinker, but I did increase my water intake. That was very important. And to try to exercise as much as I can with my schedule. That's still a work in progress, but I do try to get out and walk as I can. And being in construction, I am on construction sites a lot and do a lot of physical things. So those are some things that I made changes in. Cut back on the fried foods, a lot of vegetables. So diet was a big key.
Thank you. Thank you very much. We have a couple more questions from our audience. This is a question about the colonoscopy prep. It says, given that the colonoscopy prep is likely a noteworthy deterrent to some folks getting a colonoscopy or repeat colonoscopy, are any panelists aware of attempts to develop an effective prep that is more palatable? I guess that would be for Dr. Azad and Dr. Rajput.
They're always trying to improve on the prep. Every year there's a new prep that they say now tastes fine and is so much better. And maybe Ms. Baloo can speak to whether or not that's true. People realize the problem, they're working on it. The goal is to clean you out. And so that's why the part of the prep I think that people don't like is the fact that, it does clean you out. But But you know, there's celebrities that pay large amounts of money to do that, so you could look at it in that way. But yes, there are people trying to make it taste better. That's for sure.
Dr. Rashford, anything to add on that particular question, or not really?
I would just say
jump in on that.
I would just say that, you know, in the past, we always use this one big gallon jug, this one product. And now we've kind of come down on the volume that we can mix something with some sports drink. So the volume is less that you have to take, but the result is the same. So, but that's what we need, right? You need a good prep to get a good evaluation.
Good evaluation. Chaplain Ridley, you wanted to say?
Yes.
I would like to improve. It did improve.
Military medicine has come a long way. For 29 years, I was with the military. So my last colonoscopy, I actually had some lemon flavored goat juice or whatever they want to call it that cleaned me out, but it definitely tastes a lot better than the green stuff.
Very good. Another question from our audience. Are there any specific measures that I could do to reduce my risk? We just talked about diet. Is there anything else that we can do to reduce the risk of colon cancer? Dr. Rajput.
Well, you know, I think we hit on that. I think diet is very important and everything in moderation. And that diet is just, you know, increasing the fiber, the vegetables, the fruits, decreasing red meats, decreasing processed meats, and also exercise. You know, what we've seen is there may not be a direct correlation, but what we've seen is a correlation of cancer incidence and cancer in younger people with the obesity pandemic. So I think good diet, exercise, and maintaining your weight would be preventive.
I'll add that if there's just one thing that you are going to tackle in terms of your diet, reducing high fructose corn syrup, there is the most data that supports that, which is everything that's in soda, but actually it's in a lot. You know, we decided to try to eliminate that from our home. I have small children. They're very bummed considering how much of the candy that's out there, but a lot of syrups, a lot of pre-made foods and sauces. But if that's the one that I think there's actually the most data around.
Thank you, thank you. Another question from the audience is, how can I encourage my friends who are not as proactive about their health and do not seem as concerned to get screened? How do we talk to our colleagues? We touched on that briefly before, but how specifically can we encourage those around us to get screened?
Open to all. I'll jump in on that. And we kind of alluded to, I think Dr. Azad mentioned something about our colleagues in breast cancer, right? How they've really taken advantage of doing this. And it almost became very, almost very chic and very fashionable. In fact, the fashion industry has models, you know, and fashion shows that are geared towards raising awareness for breast cancer and raising money for breast cancer research. And, you know, most people don't want to sit around and talk about the colon or the rectum, and there's certainly no fashion models for the colon or the rectum, right? But it's a part of your body. And I think that's the acceptance, right? If your elbow's bothering you or your shoulder's bothering you, you're gonna go get that addressed. Well, if you're having a gut problem, you have to get that addressed. So I think what we're doing tonight is really important, is just talking about raising the awareness and the problem that it is. And the most important thing that if you take away from this, is that's been mentioned a couple of times, is this is a cancer that's totally preventable, right? And so, you know, we have made some progress because we've shown that screening does save lives. And so I've been doing this for over 20 some years now. And the good news is that when I started my career, I used to say that we lose about 56,000 people from colon cancer or rectal cancer a year, right? And that's down now to more closer to 46, 47,000. So we've made advances. But we live in the DC area, and I think all of us have been down to the Vietnam Memorial Wall, right? Veterans Memorial for Vietnam. There are 56,000 names on that wall. And each of us who stood there has felt the awe, whether or not you had a family member that sacrificed all in that war. But you think about that, while every year, almost the same amount of people lose their lives from colorectal cancer as we lost through the entire Vietnam War. So it really takes a huge impact and a huge toll. So it is something we have to talk about because we can prevent it. And if we catch it, we can talk about colon cancer and cure in the same sentence.
Thank you very much. Just a quick reminder for the people that are watching our webinar via Facebook, that you can also submit questions to the panel via your Facebook links, and we will get the panelists to answer those questions. In general, there are two things that we addressed at the very start, that there's a disproportionate amount of colon cancer in African-American people, but also in younger people. There seems to be a rising incidence in cancer in younger people. What is it about, is there anything specific that makes the increase in cancer amongst younger people? And how do we allay the fears and anxiety of people to get screened? What can we do, and why is it that the cancer is starting to have an uptick in younger people? Dr. Azad.
Well, you know, so this has now been well described that over the last 15 years, the average age of people who are getting colon cancer is ticking downhill. And that's why now screening guidelines have changed to 45. But we don't have a single reason that we can point to and say, this is what's causing it, which basically implies that it is something environmental, that it's something that's associated with diet and with just the kind of health that we're as a population in now, that is changing our risk and making it easier for people to get colorectal cancer younger. So because of that, because we don't have one thing we can tackle, that's why we talk about, you know, healthful living and these different parameters that we can do to try to encourage people to live life in a healthier way. Now, in terms of the anxiety, you know, I think that the more that we destigmatize this and talk about it and just make it kind of one of those things that you do, that I think I really do think that that's going to go away with time. It's just a matter of talking about it more. And there are a lot of ways to screen besides colonoscopy, you know? So there's a lot of things that we can do, like we were talking about with the stool tests. And then some of the things that I think are quite exciting is I really believe that we're 5 years, maybe, you know, maybe less, maybe more, but 5 years away from having blood tests that will be able to help us as well. And so I think that is another area where we might be able to do screening in a different way that would also be helpful.
Very good. Dr. Rashford, did you have anything to add to that one particular question, or?
No, I think the only other thing that I would add is the importance of, you know, the advocacy that Ms. Baloo brings, because, you know, she's a survivor from this disease. So if we're trying to allay those fears, having her tell her powerful story like she has, I think is very effective. So thank you for sharing tonight.
Yes. Ms. Baloo, when you were initially having your conversations around your colon cancer, there's always anxiety about having a cancer, but did you have reluctance to talk about it even beforehand? And also, Pastor Ridley, you can follow up on that from a spiritual perspective. When people come to you, are they just really reluctant to mention cancers in the first place? Ms. Baloo.
No, I was not reluctant to talk about it because, you know, like I said, no one in my family had cancer, and if it was an unknown factor that I wanted, you know, I wanted everybody to be aware and address it. And so that was my reasoning, you know, to educate my family members and to make them aware.
Pastor Ridley?
That's a good question. I work on the oncology ward at Suburban, and doing my rounds, and as well as at Walter Reed, most of the time people do not talk about cancer per se. They might talk about their situation, but rarely do I find anybody talking about cancer or the prognosis that it could be impending death. The few people that have talked about it have been very faith-filled people. So they had a solid faith in God, and those people was able to talk about family decisions. They was able to talk about their condition, the outcome, the prognosis, the process, much more freely than all the other patients that I've seen. So that's very interesting. I never thought about it before, but seems like the people who have more faith are more open to talk about their circumstances honestly and openly. Everybody else is more of, we have generic conversations about getting well and getting better.
Very good. Getting back to our audience questions, we have a question from Mr. Ernest Franklin Jr. He says, I was once provided pills for the colonoscopy prep. Is that still an option? Pills for the colonoscopy prep.
The pills are usually given in conjunction with everything else. Those pills are usually a type of laxative that helps get things going, and then you take all the liquid. But it's never just pills alone.
Never just pills alone. So from Mr. Franklin, we can't spare you from the liquid. Another question is from Mr. Clyde Williams is, what is the frequency of colonoscopy? How often should people get colonoscopies? Dr. Azad.
So it varies. There's a lot of different factors that go into it. What someone's family history is, how young that person was that got colon cancer, and if they have a personal history of colorectal cancer. And so there's not a one size fits all answer. Broadly, people should be getting colorectal cancer screening starting at 45 every 5 to 10 years. But if you get a screen and you have a polyp, then you get a colonoscopy before that 5 years. So I don't want to give an answer that tells people the wrong answer, because it's different for each individual person. But your gastroenterologist and your primary care doctor will be able to talk you through that after you have your first one.
Very good. We have a question from Mr. Calvin Parker. He's also a physician. He's a gastroenterologist in the community. He says he performs screening colonoscopies almost daily, yet he also realizes certain demographics remain suboptimally screened. What strategies do you recommend providers engage in to specifically interface with underrepresented populations in order to enhance access and screening efforts? Dr. Rajput, let you take that one first.
Sure, I can tell you a little bit about what we're doing. And I think, you know, from the Kimmel Cancer Center, we now have partnered with the Unity clinics in Ward 7 and 8. And we've positioned our nurse practitioner and a nurse navigator to help navigate patients to us for care once they're diagnosed. But the other thing that you mentioned is the enhanced screening for these populations. So I think there's a short-term and a long-term plan too. So the short-term plan, we started doing some colorectal cancer screening events. Our first one was on March 12th, and the week later, by government mandates, we all shut down because of the virus. So that really has delayed our screening plans. But we do have that underway. But I think the other thing, and really for the long term, in the education and prevention and screening, has to do with educating our communities. I had a meeting today where we were discussing ways that we can get navigators into our communities. So people who specialize in public health, and hire community workers to take that message into the communities, whether that's in churches, beauty salons, barbershops, or housing communities, where we can provide that message and those screenings. I know for mammography, they have mobile vans that can go into communities and do that. We can't do that for colonoscopy, but some of the other things for the blood test that Dr. Azad was alluding to, and that Ms. Baloo had when she was first diagnosed, we can do that in the communities as well. So those are some things that we're working on right now.
Thank you. Dr. Azad, would you like to add anything to that?
Well, I just want to commend Dr. Parker for coming to this forum, because I think the more physicians that are engaged in first acknowledging the problem and then working on being part of that solution, I think that is going to be the way that we're going to get this to broaden nationwide, right? We are very committed at Johns Hopkins and in the Cancer Center to working with our communities, both in Washington, D.C. and in Baltimore. I'm Baltimore based, and we also have a mission with our community in Baltimore as well. But we're going to have to do this on a broader scale for us to really have the meaningful impact we want to have nationwide. And I think that that's really getting providers out there learning about what these disparities are, really at the primary care level, you know?
Very good. Well, we've had a lot of facts about colorectal cancer tonight. I have one last question. What are some of the myths that you all have heard about colorectal cancer in the community? I know approach this from different perspectives. Obviously, the doctors from the medical perspective, Chaplain Ridley, and then Ms. Baloo from her own personal perspective. But what were some of the myths that you hear that you have to tell people that, you know, this really is not true, so that people won't fall to false information? Anybody can take that one first, because
I've had a lot of patients who have thought that it meant they were definitely going to end up getting a colostomy or having a bag, an external bag. And that is a very frightening thing when you're first dealing with the idea of having this diagnosis. And that is something that some of our patients have, many of our patients temporarily, but the majority of patients don't actually end up needing to have. And so I think that that's a myth I see regularly.
There are two things that I would point out. One thing that's really important, especially in our Native American populations, and I moved here from New Mexico, and I had the opportunity to take care of a lot of natives. Their thinking was, it was hard to get screening because the thinking was, if you talk about it or you think about it, you'll get it. So don't talk to me about screening for cancer. So I think that's one thing that we have to get over. The other thing from a surgical perspective that I think is really important, a lot of patients say, well, if you do surgery on me and the air touches it, the cancer is going to spread. So that is an old wives' tale, and that's not true. So in the way that cancer surgery is done today, it's a very precise, and the surgery in of itself does not spread the disease.
Very good. Chaplain Willie, do you have anything to add to that? Do you hear any myths you talk to your parishioners?
Well, actually, I think one thing, military is such a young population. So they're usually under 45, so they don't have to deal with it. So I will say that this is just reinforcing how little the young population and the African-American community talks about illnesses or cancer or anything. I haven't heard any myths or any wise sayings because the subject is not talked about that I've heard of.
Mr. Baloo, any myths that you were confronted with?
I would say I would have to agree with Dr. Assad with some statements that she made with the myths on the colonoscopy bag. With me having 15 inches of my colon removed, I did not have to have one. So that was a definite myth. Some of the other myths, I believe I heard that, just with the whole colonoscopy process, that it was, a very uncomfortable or maybe painful thing to go through. For as many as I had, it was never really uncomfortable. Of course, the prep is, something in its own, but it's really not that bad overall to get to the bottom line of your condition. So for me, the prep's not that bad, and going through the colonoscopy process was not a bad thing at all.
Thank you, Ms. Baloo. Well, I'd like to thank all the panelists tonight. We've had a very robust discussion. We've kind of touched a wide range of topics around colon cancer. Dr. Rajput, Dr. Azad, Chaplain Ridley, Ms. Baloo, we really appreciate your time and efforts tonight, and thank you so much. I'd also like to thank the audience that's tuned in via Zoom and also via Facebook. The fact that you tuned in means that you're actively involved in your healthcare, which is what you need. You need to be your own best advocate. So take heart in knowing that this is a preventable cancer and go get your screening. But thank you everybody for tuning in. I also like to give thanks to our program partners tonight. The Alpha Kappa Alpha Sorority Incorporated, specifically Omega Chapter, the Alpha Phi Alpha Fraternity Incorporated, who are health partners with Suburban Hospital. The chapter has been health partners with Suburban Hospital for the past 15 years. Montgomery County chapter of Alpha Phi Alpha. I also like to thank the National Panhellenic Council of Montgomery County, which Ms. Baloo is president of. Thank you for joining in. Suburban Hospital Community Health and Wellness. Without them, this program wouldn't be possible. And also the Sidney Kimmel Comprehensive Cancer Center, as well as Johns Hopkins Medicine. We have our two great doctors that are representing from them. And also the Montgomery County Cancer Crusade. So please, everybody, thank you for joining in. We really appreciate your input. Go get screened. The life you saved may be your own.